Hey, you amazing people out there. I know it's quite long since I have posted something, but today I have come up with a very electrifying topic we all need to understand and learn so that we can prescribe in a more wholesome manner. Today's topic is myocardial infarction, so sit back and enjoy the learning process. Myocardial infarction, which was first discovered by William Haberden. Myocardial injury, that means the troponin level should be more than that of 99th percentile. We have types, that is the type 1, type 2, type 3, type 4 and type 5. So briefly let's just look what is it. Type 1, that is atherothrombotic occlusion. Type 2 is a demand supply mismatch. Type 3 is actually a sudden cardiac death which is occurring. Then type 4 is post PCF. Then we have 4A, 4B, 4C. We'll be looking into the details later on. Type 5 is post CABG. So whenever we see a raised troponin level, that means there should be a myocardial injury. So what are the causes of elevated troponin level? So there are multiple causes. Why is it important to learn so many of the causes? Because in casualty, we have seen many patients which are occurring and they will be complaining of chest pain or any other symptoms of chest pain or jaw pain or like that. And then we'll be doing the troponin levels and then we see that yes, it is rising. So this chest pain could be like an GRD, that could be an acidity or anything like that. So we need to first of all differentiate. We need to look into detailed history, and we of course the ECG matters, but the troponin levels also are important. Even in the aortic dissection, even in the pulmonary embolism, the patient would be having a chest pain. So we have atherosclerotic plaque, wherein there would be raised troponin levels. There is a coronary embolism, coronary artery spasm, artery dissection, sustained bradycardia, hypotension or shock, respiratory failure, severe anemia, sustained tachyarrhythmia, severe hypertension with or without the LVH, heart failure, myocarditis, cardiomyopathy, Takotsu syndrome, coronary revascularization procedure, catheter ablation, defibrillator shocks, cardiac contusion, sepsis, infections, chronic kidney disease, stroke, subarachnoid hemorrhage. Next is the pulmonary embolism, pulmonary artery hypertension, amyloidosis, sarcoidosis in a critically ill patient, and of course after strenuous exercise. Myocardial injury due to ischemia, so that will lead to an acute myocardial infarction, and whenever there is a myocardial infarction or any myocardial injury which is occurring, that leads to a symptom of chest pain, and there will be elevated levels of troponin. So we know that there is something called as Levine sign. Okay, so the patient will be coming with the fist of the hand towards his chest and in an utter pain. Let's look into the type 1 atheroembolic occlusion. There would be symptoms of ischemia. There could be ECG changes, pathological Q waves, imaging evidence. That means there will be loss of viable myocardium, regional wall motion abnormality on 2D echo. There will be intracoronary thrombus on angiography. And of course, there will be raised troponin levels. So, with any of the five, along with the troponin levels, that will lead to a diagnosis. Then we have a type 2, that is a demand supply mismatch. That means there isn't any occlusion, but there will be vasospasm or there will be another other causes of it. We'll see that later. So there will be easy changes, there will be symptoms, there will be pathological Q waves, on 2D ego, regional wall motion abnormality, loss of viable myocardium, any one of the following, and there will be raised troponin levels. So the type 2 includes chronic illness, fixed coronary atherosclerosis, coronary spasm, coronary embolism, artery dissection, respiratory failure, severe bradyarrhythmia, severe tachyarrhythmia, anemia, hypotension, shock. Then there is a subendocardial ischemia. So the subendocardial ischemia is there is elevations of the in the AVR, and there is resting depression in 2-3 AVF and V2 to V5, right? So now this could be due to severe anemia, and we need to correct the illness or the anemia part, and these elevations and depression will disappear. So one of the MCQ topic, the commonest cause of MI in pregnancy is the spontaneous coronary artery dissection. Coming to the type 3. there is a sudden cardiac death. So sudden cardiac death, the statement itself explains what it is. That means the patient will be presenting with the symptoms and the cardiac markers are not obtained, right? And there will be death, of course. So there will be death before the cardiac markers are obtained. Patient who suffered the cardiac death, symptoms suggestive of myocardial ischemia, and new onset ischemic changes on the ECG. Type 4 MI, that is PCI related. So we have 4A, 4B, 4C. 4A, that means there will be troponin levels raised. How much would be 5x? And there will be new onset ischemic changes, new pathological QVs, loss of variable myocardium or RWMA. So the symptoms part, right? And the we see the ischemia of the symptoms. These will be not there in the PCR related, that is 4A. We're talking about the 4B, that is stent scaffold thrombosis. Symptoms is present, ECG changes, pathological Q waves, loss of variable myocardium, and there will be identification of stent with the or the scaffold thrombosis with elevated troponin levels. So that is this time frame. This time frame suggests that whenever there is decrease or less than that of 1 day, there can be an acute stent thrombosis. 1 day to 1 month subacute, 1 month to 1 year, that is the late stent, and more than 1 year, that is the very late. So in the stent thrombosis is a deadly condition. Remember this. Coming to the 4C, in stent restenosis, that mostly occurs after the PCS, that is 6 to 9 months after the PCI. There will be symptoms of ischemia, new onset ECG changes, there will be pathological QS, there is loss of variable myocardium or RWMA, in identification of instant restenosis on angiography. Of course, there will be increase in troponin levels, so any of the 1 and troponin levels. Coming to type 5, that is a CABG related, like that of the PCI 4A1. This also, there will be troponin levels that is more than 10x. And there will be new pathological QVs. On the angiography, we have new graft occlusion, new native coronary artery occlusion, loss of variable myocardium or RWMA. So what is the difference between a reinfarction and recurrent MI? So this MI, which is occurring within 28 days, and the MI, which is after the 28 days. Okay, so this could be like symptoms, ECG, and of course troponin. We can identify this. Old MI, whenever we say it is an old MI, we have Q waves in this, right? So there will be abnormal Q waves with or without the symptoms. There will be loss of variable myocardium. Okay. Coming to the pathology of the myocardial infarction, we all are familiar with the plaque. So it could be a vulnerable plaque, it could be a calcified plaque, or a plaque erosion. So plaque erosion mostly females and calcified nodules in elderly one, wherein the stenting is very difficult. Vulnerable plaque can rupture, right, and cause MI, which is the most common one. Histopathology wise, we have a thin fibro atheroma, right? We have a thin cap in that. We have a necrotic lipid core, increased macrophage infiltration. There is decreased smooth muscle contained. There is spotty calcification. There is eccentric remodeling, right? And we have certain diagnostic criteria for the vulnerable plaque. So there is a major and there is a minor criteria. Talking about the major criteria, there is an active inflammation, that is the macrophage, which comes in. Okay, we know that smooth muscle cells are decreased, and there is increase in macrophage, and there is increase in lipid core. Then there is a thin cap which is coming. There is endothelial denudation, there is fissure plaque, and there is stenosis, which is more than that of 90%. Talking about the minor criteria, it is a superficial calcified nodule, glistening yellow, intraplaque hemorrhage, endothelial dysfunction. There is outward remodeling. So we have occlusion of the artery, right? So this occlusion is actually, we know that there is a necrosis happening. So what type of necrosis? It is a coagulative necrosis. There is a contraction band necrosis. In the earlier days, we have a neutrophilic infiltration, and then in the after 4 days, that is 4 to 7 days, we have a macrophage infiltration. Now, something that is not very common, that is a preconditioning. Now, preconditioning is when in the heart is subjected to certain stress, right? Ischemic stress, decrease in the blood flow. And then there is actually a condition where the heart is able to recognize certain ischemia, certain injury which is occurring, and that is a reversible, right? So it is a brief period of reversible ischemia prior to prolonged occlusion, which it helps the heart to reduce the infarct size. So previously in normal coronaries, there could be large obstruction occurring, and that could lead to large infarct. So there is a biphasic effect of ischemic preconditioning. So we have this is classic and delayed 0 to 4 hours and 4 hours to 4 days. What is the mechanism of the preconditioning? The first window, there is adenosine A1 receptor, there is a protein kinase C, there is opening of the mitochondrial potassium channels. Now, what are the drugs which are actually helping in the preconditioning? That is the phosphodiesterase 5 inhibitor, sildenafil, potassium channel opener, that is diazoxide and nacoran. Drugs which are decreasing the preconditioning, that is the potassium channel blockers, sulfonyl ureas. The mechanism for delayed, that is the second window, 4 hours to 4 days, upregulation of inox and COX-2, opening of mitochondrial potassium channels. So one of the MCQs here and there, we should know the mechanism, inox and COX-2 and upregulation mitochondrial channels in the window 1, that is because of the opening of the potassium channels. We have the adenosine kinase and adenosine receptor stimulation, protein kinase. Something which is called as milking phenomenon. Okay, that means there is whenever there is a BP cuff, right? So BP cuff, whenever we are inflating, and then there is a systolic compression that will lead to a myocardial bridging, and that is leading to a LAD block. So remote ischemic preconditioning, increasing in the peak period ischemia, that is also preconditioning phenomenon. So that is actually cardioprotective. Okay, remember this box. Remote ischemic preconditioning stimulus is given. Then remote ischemic preconditioning single mechanism. I hope you all are able to see this. It is a cardioprotective mechanism. Okay, cough inflated, then there are certain systemic inflammation which is occurring, and it will lead to an injury, but that is actually for a brief period and it is reversible. So mediators, we have already seen adenosine, then certain erythropoietin, platelets, okay, amino acids. Something called as post conditioning. So that is actually a protection of the myocardium from the lethal ischemia, that is a reperfusion injury. We all are familiar with this word, reperfusion injury. So whenever there is an MI, there will be ischemia, the blood flows, and whenever there is ischemia, so whenever we are actually lysis or have occurring, or it is spontaneously reperfusion is occurring, so that reperfusion, there will be actually a toxic metabolites and the free radicals that would be in the place of that occlusion, and that whenever that occlusion is uh, getting back or getting away from that occluded site, and it will carry all the toxic metabolite and the blood flows through it and to the all the parts of the body. So release into the bloodstream. So toxic metabolite, lactic acid, free radicals. Activation of reperfusion injury, salvage kinase pathway. So the sinus kinase pathway that occurs. Then there is something which is myocardial stunning, and there is actually myocardial hibernation. Very important, very interesting topics. Now, what is stunning? Stunning means there is acute total occlusion, followed by there is reperfusion, results in a depression of the myocardial function. So the blood flow is restored. So there will be first the acute occlusion, then the blood flow is restored, right? But this will lead to depression of myocardial function. Okay, depressed, right? But there is no myocardial necrosis. This is very important. So this is because of free radical mediated injury or reduced myofilament calcium sensitivity. Then coming to the hibernation, that means there will be chronic obstruction. Okay, chronic obstruction will be present. So chronicle dysfunction myocardium, chronic, there will be decrease in the blood flow. So, but there is also no necrosis in this, right? But blood flow is enough to remain viable, remain the myocardium to be viable, which has a potential to regain the function once the blood flow is restored. So the blood flow severely depressed, right, and it is chronic occlusion. Myocardial function is depressed. There is no necrosis in this also. So what is the difference? Acute, chronic. No necrosis, no necrosis, right? And vessel wall are restored in this. In this, there is no restoration of the blood flow, but the blood flow is depressed in such a manner that the cells are viable, remaining viable. Okay, so there is this difference. Coming to the symptoms. So what are the symptoms you should be thinking if the patient comes in a casualty? Any patient who is suffering from a chest pain, who is in middle age, right? You're elderly, consider it to be an MI. That is the first rule. Second rule is patient comes at the night and it is actually a cardiac pain, right? Third rule is patient is forced to get up from sleep or forced to get up from his work and he could not concentrate in certain things. That means it is MI. In general, fourth rule is in general the patient has a previous angina and then he is saying that the same type of the pain he is experiencing considered to be the MI, right? So disappearance of the prolonged cardiac pain means we cannot say it is fine, it is over, it is good. No, it means that the myocardium is dead now. That's why pain is not present. So the cardiac pain more than 20 minutes, that means it is an MI. When will we call an ST elevation MI? Very, very, very important, basic, right? ST segment elevation at the J point in two contiguous leads rather than that of V2, V3, and it is more than that of 1 mm. So V2, V3, what do we see? V2, V3, we see that if it's a male or a female person. Now, if it is a male person, if the age is very important in this, more than equal to 2 mm in men, which is more than 40 years, or more than equal to 40, or less than 40 years, then it is more than 2.5 mm, right? And in females, it is more than that of 1.5 mm, regardless of the age. And STEMI, when do we call it as a non-ST segment elevation? Whenever there is actually a downsloping or horizontal ST depression which is more than equal to 0.5 mm in a contiguous leads, and there will be also T inversion which is more than that of 1 mm in contiguous leads with a prominent R or R slash H which is more than that of 1. So the least represented territory on ECG is L6. L6 block will not be present. What are the causes of ST elevation? Like that of troponin, many causes: myocardial ischemia infarction, acute pericarditis, early repolarization, LVH, LBBB, acute pulmonary embolism, Brugada syndrome. Then we have the antiarrhythmic drugs, hypercalcemia, hyperkalemia, hypothermia, intracranial hemorrhage, myocardial injury, myocarditis. So we have a giant T inversions. So giant T inversions are nothing but in limb leads and chest leads. What do we need? See, whenever the T inversions are present more than that of the 5 mm in the limb leads and more than 10 mm in the chest leads. Now, why is it important? Because it denotes that it is a atypical HCM. Then it can be a coronary artery disease or myocardial infarction. It is post CPR patient or DC shock and cerebral T inversions. Okay. Whenever we're talking about the posterior STEMI, that means more than that of 0.5 mm elevations in the posterior leads, right? So let's differentiate three things: ischemia, injury, infarction. What do you see? Infarction, infarction means ho gaya, khatam. It is like over. So pathological Q waves have occurred. Already there is a decrease in blood flow and everything is dead. Then we have injury. Injury means that is ST elevation has occurred. So there is now we need to do something. Okay, urgent action needed. Then we have ischemia, that means there could be a T inversion and ST depression. So we have seen many of the patients who are coming and there would be chest pain and then they say that I'm all right now in 1 or 2 hours and let me go home. But there will be T inversion. We say no, you have to admit for 24 hours. So for the serial ECG monitoring, yes, these are the things. That is ischemia has occurred and we need to do 2D echo and probably CAG for that patient. So T inversion and ST depression, right? So why do we misdiagnose ACS as a GERD or reflex? Because of the similarities, right? Up to 50% of the MI patient symptoms are like that of the acidity or something. Then 20% of the patient describe angina pain as a burning and indigestion. Then we have 15% of the patient get improved by antacids. 8% of the patient report their symptoms started after meal. Okay, so they are frequently coexisting many of the times. Okay, patient are experiencing acidity also and is actually a angina pain also. So these are the features. Now something it is called a pseudonormalization. Very important to understand balance syndrome, right? Patient has chest pain, patient will be having ECG normal. Now how could this be possible? Okay, so once the patient is coming to us, their first ECG is taken. T wave is inverted, okay, as the artery opens. T wave inversion, that means there is certain ischemia which is occurring, okay, when the thrombus occludes the artery. So the T wave inversion is changing to ST elevation. So that means there is injury that is occurring, right? So the inversion goes up and this is a normal ECG which is seen in Wellen syndrome. Very important. I will show the image of the Wellen syndrome also, and these patients need CAG in 14 days and the TMT should not be performed in this as patient can collapse. In the Wellen syndrome, we have characteristic T wave changes. We have history of anginal chest pain, right? Normal or minimally elevated cardiac enzyme, ECG without the Q wave, without a significant ST segment elevation. So, see over here, these things. These patients develop extensive anterior wall MI, very important. CAG is compulsory in these patients. Then we have something which is D Venter's sign. D Venter's sign, there will be at the J point itself, there will be ST depression. Okay, and of course the T wave will be so much bigger, hyperacute. Okay, so this is the D Venter sign, and this is also proximal LED occlusion. In Valence also there is a proximal LED occlusion. Okay, these both denote proximal occlusion. So remember the J point, there is ST depression and hyperacute. This is very important. De Venter's T wave, proximal LED occlusion. Take the patient for CAG as soon as possible. Then we have the LMCA or LMCA equivalent. So LMCA or LMCA equivalent, why is it important? Whenever there are elevations which are occurring in more than that of the 5 Ds, and that is very, very dangerous. Okay, so there will be extensive broadening of the QRS complex along with it, and that has a bad prognosis, and that denotes triple vessel disease. Okay. Scarboza criteria, LBBB, using it on daily basis. So there would be concordant ST segment elevation and more than that of the 1 mm. Okay, so that is concordant ST elevation, that denotes 5 points. There will be ST depression which is more than equal to 1 mm in V1 to V3, that is 3 points. And there is discordant ST elevation in more than equal to 5 mm, that is 2 points. If the patient is suspecting a proximal LAD block, how do we see the patient? So the patient will be suffering from LBBB. Why? The left bundle branch and the right bundle branch, okay, they are supplied by LAD. Okay. Now more towards the this part, okay, LBBB, because there is ST elevation in V1 which is more than that of 2.5 mm, okay, and there is ST depression in more which is occurring in V5 and V6. Also there is ST depression in 2-3 areas. So remember 4 points towards the proximal LAD. First remember V1, okay, V1 more than V2 elevation would be there, okay, that is the proximal LAD. Then depression in 2-3 AVF, then depression in V5, V6 and RBBB. Okay, any one of these is enough. Then we have something which is wraparound LAD. That means LAD in some cases is too long and it actually goes to inferior wall and supplies the inferior wall. So that is a wraparound LAD, and that means there will be elevation in 2-3 AVF that we see in the inferior wall MI. Okay. If there is an inferior wall with the right wall MI, that is mostly seen in 50% of the population whenever there is a right wall MI. So remember the elevations will be in 2-3 area because of inferior wall MI. So the elevations will be more in 3 as compared to the 2. Okay, and the depression is more in AVL as compared to the AVR. That means that the RCA is blocked, proximal RCA. Okay, remember that. So we are talking about AVR and AVL. Depression. See to the depression. AVL depression is more than AVR, and the 3 elevation is more than 2. That means it is the proximal RCA which is blocked. Proximal RCA, RVMI, synodal conduction disturbances and atrial infarction. Okay. If you are talking about an LCX block, ulta. ठीक है, lead 2 elevation is more than lead 3 and AVR is more than that of AVL. Depression rise. ठीक है, we have already seen triple vessel disease, LMCA equivalent, right? Coming to the troponin levels. Troponin levels, we see that TROP-T and TROP-I both can be done because 7 to 14 days, 7 to 10 days, it's okay. Myoglobin levels, which is actually very fast and peaks 24 hours and not done, right? So on the basis of ECG and clinical diagnosis, we can lyse the patient. Do not rely on the trop. So high sensitivity trop can be done on the admission and after 1 hour. And if we see that the normal trop which we are doing in our labs, so we can do it 3 to 6 hours. Okay. Now the trop ticket by cardiologists are not recommended. Remember this. So 2D echo is done for looking for any of the septal ruptures or any complications or tamponade or embolisms, right? And also for the dissections, okay, and RWMA. Where do we do CT in the chest pain? In chest pain. So if it is for MI, it is for aortic dissection and pulmonary embolism. So remember these MCQs: MI, aortic dissection, and pulmonary embolism. Cardiac MRI, just a brief one: transmural, subendocardial. Transmural, whole of the myocardium is involved, so it has a bad prognosis and good prognosis in case of a subendocardial, right? In MI, what are the other things that could be seen? In CBC, there will be increase in TLC. We see it as a reactionary one. And then we have the increase in ESR also, that is in almost in 7 days. Okay, it peaks in fourth or fifth day, remains elevated for a week. Then CBC peaks in 2 to 4 days. There is something which is called as myocardial infarction, non-obstructive coronary arteries, MINOCO. That means there is a coronary arteries wherein there is infarction which is occurring, but it is a non-obstructive one. So what are the coronary causes for it? Then it is a vasospastic angina, microvascular angina, coronary plaque disruption, spontaneous coronary thrombosis or embolism, mixed obstructive CAD. Non-coronary, we have myocarditis, Tokosu, DCM, HCM, pulmonary embolism, renal impairment, stroke, sepsis. So this is for today. We will be shooting on management later on, and I'll upload the video for you. Thank you so much for listening.